Welcome to Around the Rheum, brought to you by the Canadian Rheumatology Association. Calling all rheumatologists, CRA Rheum Review is back on February 20th, 2026, and you won't want to miss it. This top-rated accredited program is your annual opportunity to refresh your knowledge, gain practical insights, and stay ahead in your practice, all in just one day of virtual learning. Register by the early bird deadline of December 12th to save. Visit rheum.ca for details.
Bottom line is there really is no evidence that baseline immunosuppression prevents flares, in which case, given the existing evidence that baseline immunosuppression may worsen cancer outcomes, thus the balance towards de-escalation.
Some of the best data comes from prednisone, actually. And there was a study that looked at patients who were on baseline prednisone. I believe they looked at patients who were getting above 10 milligrams per day. That prednisone study was one that kind of suggested an early signal that we might be blunting the effect of these drugs.
That's Dr. Jeffrey Graham and Dr. Carrie Ye joining us for this special episode of Around the Rheum, taking a deep dive into the new CanRIO guidelines. Welcome back to our listeners. I'm Daniel Ennis, and I'm joined as always by my co-host, Dr. Janet Pope. Welcome back, Janet. How are you?
Very well, and I hear you had a lovely trip to Japan.
I had the best time. I'm sad to be back, but I'm happy to be here with you.
We're glad to have you back.
I have a little pre-interview question for you, Janet. Any chance you know who the 16th author of this guideline is?
It might start with a J and end with a P.
Okay, I was hoping to.
I thought it was the 17th.
Dr. Pope is also an author on this guideline. I was hoping that I would catch her not knowing that she was an author on this paper, but she still got it. Let's get started then. Dr. Carrie Ye is a rheumatologist and associate professor at the University of Alberta and at the K Edmonton Clinic at the University of Alberta Hospital in Edmonton, where she runs the Rheumatology and Immuno-Oncology Clinic. And Dr. Jeff Graham is a medical oncologist at Cancer Care Manitoba and an assistant professor at the University of Manitoba. He specializes in genitourinary cancers with a focus on kidney cancer and immunotherapy. Welcome to you both. Thanks for being here.
Thanks for the invite. It's a pleasure.
Yeah, thank you very much.
So today we're discussing new guidelines produced by the CanRIO Research Group. That's the Canadian Research Group of Rheumatology in Immuno-Oncology, with support from the CRA. This was published in the Journal of Rheumatology in September 2025, and it's authored by a large group of easily the smartest doctors in Canada. So if you do not routinely follow the products from the CanRIO group, educational and research, you absolutely should. The CanRIO Living Guidelines for Baseline Immunosuppression in individuals with pre-existing rheumatic diseases initiating immune checkpoint inhibitors is divided into two parts. So part one deals with pre-existing inflammatory arthritis with particular recommendations made for rheumatoid arthritis, PMR, psoriatic arthritis, and spondyloarthritis. And then part two is pre-existing systemic autoimmune rheumatic diseases such as systemic sclerosis, lupus, Sjogren's, myositis, sarcoid, vasculitis, and Behçet's. This is a massive undertaking. They're really impressive documents. And just to set the table, I want to go back to basics a little bit. I want to discuss a few competing interests that you would have to wrestle with to compose these guidelines. And to get us there, Carrie, I was hoping that you could outline the landscape for rheumatologists. And maybe the best place to start is, what's the risk of flare of pre-existing rheumatic diseases in patients who are going to start immune checkpoint inhibitors or ICIs?
That's a great question, Daniel. And honestly, the answer is that it really depends on the pre-existing rheumatic disease. And that's partly why we pursued these guidelines, is that we got tired of just having all pre-existing autoimmune diseases lumped into one category for guidelines, recommendations, studies, when we know as rheumatologists, these are really distinctive diseases with different prognoses, different treatments. And so I would say there probably is a risk of flare for every pre-existing rheumatic disease. but that really differs depending on the disease. For example, the risk of flare of pre-existing PMR is probably super high, much higher than 50% versus maybe some other diseases that risk is lower.
Fair enough. Maybe then turning to you, Jeff, can you explain the concern that oncologists have about the use of immune suppressants in patients on checkpoint inhibitors? Like, why do we need to collaborate on this at all?
Yeah, I think the concern is both theoretical and based on some small sort of observational data. I think the idea is that these drugs work to activate our own immune system to try to promote an anti-tumor response. And if someone's on a baseline immunosuppressant, that might blunt the effectiveness of these drugs. So more of a theoretical sort of risk. I think there is some emerging data, though, that patients who are on some form of baseline immunosuppression may have inferior outcomes or lower activity to these drugs. I will say the data is not robust, though, and I think we need to generate more data on like how or what the magnitude of impact is of immunosuppressants on these drugs, and that's the background from an oncologist point of view.
Janet, like you are a super busy clinician. I'm curious, are you seeing much of this patient population?
I am because we're part of the CanRIO registry. So the oncologists appropriately have caught on that we will see them really quickly because our big thing, Jeff and Carrie would agree, is that we don't want the patients to get delayed therapy. So we get the consults probably in three areas. Our patients, they have now an oncologic illness, and whether it's chemo or, of course, the checkpoint inhibitors, they want to know what comes off, what stays, what's the risk of flare, or they're even well controlled and they just want to make sure it's okay to give appropriate treatment. That's one kind of consult. Another is inactive patient. Maybe we haven't even seen them for years, but is it okay that are we going to make something wake up because they want their appropriate treatment? And then the other ones are treatment is going to start or has started with a checkpoint inhibitor. And now there's a concern of flaring the underlying disease or a new disease has come. And sometimes the new disease is, we'll call it like when Carrie mentioned PMR or rheumatoid arthritis like, that they're not necessarily identical to what we would see in our usual classical patients. We get the patients coming from all those reasons, and we do get them in quickly because we always want life prolonging or quality of life prolonging therapy to be given as long as we can deal with any fallout.
And that sort of brings up the push and pull of these guidelines. So I do see a particular challenge in writing these guidelines because of that push and pull between the need to treat the cancer and the need to treat the rheumatic disease and the risk of flare. So before we actually get to specifics of the recommendations, I am curious, like having an oncologist and a rheumatologist here, how do you harmonize those two perspectives into a guideline like this? I would imagine that those would be really challenging discussions to have for like Delphi scoring and such.
Yeah, totally. And I think we were thinking about those sort of push and pull factors when we designed our systematic lit review. So we looked at both rheumatic disease outcomes and cancer outcomes. And so the data we extracted, or certainly tried to extract, the evidence is not great, is we tried to extract both of those outcomes so that we can make a balanced decision for each of these diseases.
That's interesting. Jeff, also before we even get into the substance of the recommendations, this is riffing on the last question I asked you, but can you give us a sense of which biologics or which DMARDs actually do concern oncology? Just if you can list those out just for listeners to have some idea of what we might need to be worried about as rheumatologists.
Yeah, for sure. I think some of the best data comes from prednisone, actually. And there was a study that looked at patients who were on baseline prednisone. I believe they looked at patients who were getting above 10 milligrams per day. And it appeared that group of patients had inferior outcomes. I think there are like other explanations for perhaps why that group had poor outcomes. So hard to make a causal connection. But I think that drives a lot of the concern, actually. With respect to some of the other novel immunosuppressant drugs that you guys use, I think the data is just really poor, or not really poor, but just low numbers. And we don't have a lot of really good data on which specific drugs are safest to give in conjunction with these immunotherapy drugs. But I think it's that prednisone study was one that kind of suggested an early signal that we might be blunting the effect of these drugs, acknowledging some of the limitations of that study.
And you do make there's a specific recommendation about abatacept in particular being of concern. Carrie, are there other patients where there are biologics or DMARDs that you avoid entirely or are worried about using in conjunction with ICIs?
I would say the only one is abatacept, and I would also say the trend in terms of my collaborations with oncologists is that oncologists are feeling much more comfortable with concomitant immunosuppression, including biologics. And I think to add to what Jeff had to say about immunosuppressants is not only is there limited evidence to suggest immunosuppression may affect tumor outcomes, like I said earlier, with lumping all pre-existing rheumatic diseases together, all immunosuppressive drugs get lumped together just probably for sample size considerations in these studies. So we don't really know which immunosuppressants may affect tumor outcomes worse than others, other than prednisone, or steroids are often analyzed separately. And our group tried to even consider, do we want to give a hierarchy of which immunosuppressants to take off first? And we really decided there's just really no evidence to guide us to do that. So we refrained from doing that. We just used terms like de-escalate immunosuppression because there's just not enough to guide any sort of recommendation in that area.
Daniel, for the listeners, I think there's two pearls. The first pearl is the reason abatacept is considered a no-no is because one of the checkpoint inhibitors is basically anti-CTLA-4 Ig, so it's anti-abatacept. So we wouldn't want to attenuate. And someday we might or might not have a PD-1 kind of drug in recalcitrant RA, and that would be also anti-immune checkpoint inhibitor. So that's one thing. I think the other thing is that we want the patients to do well, and a pearl is sometimes before they get their checkpoint inhibitor, they've actually had chemotherapy. Not everyone, and it does always depend on the cancer type, but a lot of times if our patient has an immune suppressive chemotherapy and then moves on to a checkpoint inhibitor, not for all diseases, but not all cancer types, but they often aren't going to flare their underlying disease that we're treating them for a while. So that gives, like, again, a lead time that we say, okay, we stopped their methotrexate because they needed this sort of consolidation chemo. And now they're at a different phase where they're getting the checkpoint inhibitor kind of stuff. So I think that makes it a bit easier. And I think the final point is it's so variable on also the type of cancer and the type of checkpoint inhibitor used because some are on two. And if they're on two, that's because protocols have said they're probably better than one. And they're more apt to wake up their disease if they're on two instead of one.
It does. I saw Jeff nodding to that last point about these cancers are different. Just the massive sort of disadvantage right at the beginning to even pull apart this literature where it's not one drug, one disease. It's multiple different diseases that we call cancer. And there are similarities, of course. The medications, biologics, have similarities, but are very different. And so you're trying to study multiple diseases, multiple medications with different mechanisms, in multiple cancers with also different mechanisms. That seems a near impossible task, but I think it's like such an admirable effort to give actual recommendations, things that are really actually will be useful as guidelines. So I really appreciated that about the guidelines. So I think that sort of leads us into part one of the guidelines. What I noticed, and this question's for Carrie, so across the spectrum of the inflammatory arthritides, the recommendations are to de-escalate immune suppression. And I was hoping to hear a little about how you got to that recommendation, because you've also articulated that PMR, as an example, is over 50% chance they're going to flare. But over 10 milligrams of prednisone may interfere with the cancer therapy. Should we be trying to come off treatment? Is there not an argument to be pushing immune suppression harder to avoid prednisone? Can you just wrestle with that a little bit for us?
I guess I should start by saying that we didn't initially intend on splitting up our guidelines into inflammatory arthritis versus SARDs. We approached every pre-existing disease separately. We reviewed all the evidence separately for RA versus PMR versus psoriatic arthritis and so on. And it was only when we realized our word count was way too high for Journal of Rheumatology that we thought we had to split it. And so when we did split it along these lines, only then did we realize that we had actually made really similar recommendations for all of the pre-existing inflammatory arthritis versus the SARDs. And I think that's good. It shows that there's like a similar logic being applied across the board. And so your question about some of these diseases have a really high likelihood of flaring. Why wouldn't you keep them on immunosuppression to prevent that? And I think that the reason our panel went towards de-escalation is that the evidence really is not convincing at all that baseline immunosuppression even prevents flare of our diseases. In fact, most studies may actually show the opposite, and that might actually reflect selection bias, and those patients who are on immunosuppression at the time of immune checkpoint inhibitors might have worse disease, and that's why they're on baseline immunosuppression. The bottom line is there really is no evidence that baseline immunosuppression prevents flares, in which case, given the existing evidence that baseline immunosuppression may worsen cancer outcomes, thus the balance towards de-escalation. The other thing I think is worth highlighting that maybe isn't highlighted enough in the actual manuscript is that there's some evidence and increasing evidence that immunosuppression at different times after immune checkpoint inhibitors are started may have different impact on cancer outcomes. Early immunosuppression may actually worsen tumor outcomes worse than immunosuppression used to treat a flare or to treat a new toxicity later on may not be as harmful. In which case, maybe our patients would do better if they go into immunotherapy treatment without immunosuppression on board, have a flare, and then they get something. That might actually be better in the long run. So there is certainly that emerging body of evidence that was considered by the panel as well.
Although, is that a self-fulfilling thing? Because those who flare are often getting a better response on their checkpoint inhibitor for controlling the cancer.
I was going to echo that comment. Yeah, it's interesting. I think there is emerging data that patients who, this is independent of whether they have pre-existing autoimmune disease, if they have an immune-related AE on immunotherapy, may have better outcomes. So yeah, it's interesting that if you treat that immune-related AE with steroids, are they having a worse outcome? Or is the fact that they've had that immune-related AE enough to suggest their immune system is activated and hopefully activated against the tumor as well? So I do think there's probably some time, like a temporal relationship or window where I think immunosuppression is probably maybe detrimental, and maybe that is when you first start the immunotherapy. But after they've been on it and they've developed a response, maybe it's not as important. More speculation, but certainly an interesting question.
That's all really interesting. Yeah, that was something that was a question kicking around even, I think, at the inception of the CanRIO group was, does having a flare of an IRAE indicate the likelihood of response? And it seems like that's still on the table. It's still being looked at. So that's a fascinating question. In part two, my contrast across the spectrum of those disorders, as I outlined above, to say them again for listeners: systemic sclerosis, lupus, Sjogren's, myositis, sarcoidosis, vasculitis, and Behçet's were the entities specifically noted. So across that spectrum of disorders, there were general recommendations to continue baseline immune suppression. And I am curious sort of how these patients, what's the distinction between these patients and our inflammatory arthritis patients? Is it the life-threatening nature of some of the manifestations, or is there something inherently different about their risk of a flare that distinguishes them?
Yeah, I would say it really is mostly the fact that there could be organ-threatening, life-threatening flares in these patients, and so that risk is something that our panel didn't feel was worth the potential benefit of de-escalation. And I will also add that the evidence for these diseases, the SARDs in general, we were relying on case reports. So we really didn't have too much evidence to say if baseline immunosuppression impacted flare rates, whereas we probably had a little bit stronger evidence in the inflammatory arthritis group.
Janet, this is a question for you, and in no way meant as like a dunk on guidelines in general. I find it helpful to have a living guideline where the data is evolving, and it's something that you can refer back to and see it's being updated as there's new information. But this guideline reflects the current status of the science. Even as in the two parts, you indicate some of the recommendations are weak or the evidence is weak. That's not suggesting poor quality of work done. It's just the status of the science. And Janet, you've been doing guidelines for a long time. Is it essential to wait for good quality evidence before you give an opinion? Or I kind of like this model where this is the opinion at the moment and it'll change over time. But I'm curious about your kind of longer view of that.
So if we want guidelines to be useful, they have to be some degree of speculation. And on some things, we had pretty high consensus, even if we had low-level evidence. And low-level evidence, no one's going to get an RCT. They've got their cancer, and now that we're going to say, we want you to be randomized to stop all your background stuff or not. That's the first thing. The second thing is always common sense will prevail and a good dialogue between obviously the patient, but between the oncologist and the rheumatologist. And I think the final thing is there's people with Behçet's and there's people with neuro Behçet's who are really sick, right? Mild, not that anyone wants genital or oral ulcers, but say if they're very uncommon for the patient at that point, because Behçet's can burn out in people for sure over time. So if someone's on a bit of colchicine, that's a far different patient than someone on azathioprine with infliximab, say, for severe Behçet's. So I think also when we're looking at these things, the longer a patient's doing well in general, the more likely they'll do well. But knowing that their immune system will be tested by getting immune therapy, that we want their immune system turned on, and that does super increase the risk of a flare. So all that being said and done, I think that the guidelines were done the best they could with the lack of evidence, but there is some degree of consensus about that prednisone early, that it's coming from multiple studies, and yes, it's not necessarily controlled, and people are on prednisone because there's already something wrong with them, so these are pre-existing illness patients, etc. But I do think to have something practical that we say low-level evidence but strong agreement is actually helpful for the community.
That's a really good point, Janet. There were times on the panel when we would look at the evidence and say, can we even make a recommendation? But thankfully, we had Jordy from CRA methodologist pushing us and saying, you are the experts in the room. People are looking to you. You have to make these clinical decisions. What would you guys do? And like Janet said, we actually had pretty good consensus on essentially all the recommendations because we actually agreed we would all do the same thing despite the lack of evidence. And why not offer what we could offer? And hopefully it's helpful to people who aren't seeing as many of these patients.
I think that also in some ways sort of reflects clinical practice where like we often, I think all of us often see patients where like the diagnosis is not that obvious and you still have to make decisions. So that is, unfortunately, that's a thing that you have to do anyways. You are going to see this patient. Should we leave Canadian rheumatologists just to like, well, everyone do whatever you want and, you know, read the literature at your leisure and be as expert as you feel like, or give some guidance based on what literature there is, and using a systematic approach as you have to establish the quality and really review with a careful eye the data as it is, I think just reflects the reality as it stands. So I think it's a really valuable document through that lens.
And one other thing, Daniel, about this, and Jeff might want to pipe in here too, is that we usually have to ask the oncologist. Like we know with the melanoma, this could be life-saving, life-prolonging. But with some of the cancers, I don't even always know, is this palliative and we're only expecting a bit more benefit for bang for buck kind of thing? Or is this to be transformational? And because it will depend on the cancer and probably the type of the cancer, like what stage are they, what are their receptors or whatever is all looked at. So, Jeff, do you factor that in if you're going to help the rheumatologist to say no way or yes, you can do it, or I don't even know what this drug is, tell me more about it? Does it matter if the goal of the immune therapy is vastly different?
Yeah, absolutely, Jen. And I think it's an excellent point. I think every year it seems like the indication for these drugs is expanding across tumor types. And like you said, within tumor types, including the curative adjuvant setting and then the kind of more palliative metastatic setting. So absolutely, I think when weighing the benefits and risks of starting a drug such as immunotherapy in someone with a pre-existing autoimmune disease, that is absolutely something that we take into consideration. Is this a drug that's going to extend survival by a few months? And maybe the risks don't outweigh the benefits. Is this a drug that can lower the risk of recurrence by, say, 40% in an otherwise healthy individual? Yeah, maybe it makes sense. So you're right. And then in some indications, they are really transformative. Like they've one of the sort of unique aspects of this class of drugs is that they can generate these durable responses, even in patients with stage 4 metastatic disease, like you mentioned in melanoma. We're seeing that in kidney cancer and other tumor types. So you certainly don't want to, not give a patient the benefit of these really durable responses, even with metastatic disease. So yeah, there's a lot of nuance that comes on down to the risk-benefit ratio or balance, which is really important for the rheumatologist to know as well. I think that's a really good point. And even for us, it gets a little bit overwhelming with the amount of approvals and new indications for these drugs. Yeah.
Jeff, I'm wondering, how was it working with a bunch of rheumatologists? How did that go?
I got to say, I was going to say at the start, but I have to give Carrie a lot of credit. This was a larger task than I thought it would be when I signed up to do this. I'll tell you that much. But it was a very, I think, enjoyable, and I actually learned a lot about guidelines. I've been involved in guidelines in oncology, but not to this scale. And the amount of work Carrie and the rest of the team put in is really commendable. So it was great. One of my colleagues is Liam O'Neill. I'm sure maybe all of you know. So he's part of the reason why I was connected to this group initially and introduced to Carrie. So yeah, I have a good friend and colleague in Liam who made the connection early.
Carrie, before we wrap, I'm curious if in putting these together, you've been writing articles on ICIs or IRAEs for a while now. Did anything surprise you in the literature as you did the hardcore systematic review? Anything surprise you when putting these guidelines together?
I think what was most surprising is the lack of data. And I say that as someone who has kept up with the data fairly well, but the fact that we were trying to dissect the different diseases and also try to match outcomes with baseline immunosuppression, all of a sudden that pool of available data just shrunk. And I think that's what surprised me is that when we started this, I actually thought there was adequate data because you hear about these big studies that are quoted all the time that give you these pretty concrete results with big significance. And then when you really go into it and you try to tease out our diseases, you realize, oh, it's not reported, or they've diced it in a way that we can't actually decipher outcomes based on immunosuppression. And I think that's what was most surprising. And when you bring up, the fact that we had to make recommendations on pre-existing SARDs on just a few case reports, I see that as the other piece of this guideline is the advocacy piece. I think that the reason we have so few reports is that for so long, these patients with these probably more severe SARDs weren't even being offered these drugs. So we really don't know their outcomes. But we also know that of the people who've gotten it, there's been some pretty good outcomes in these patients. So we really should be advocating for them to be offered, especially in those cases, like Jeff just said, where it's transformative, potentially life-saving. These patients should be offer these treatments, and then we should be reporting on them so that we have better evidence the next time we do an update.
And I think that would be a heads up for CanRIO because the database does both collecting our already rheumatic disease patients who then have cancer and are offered or receive checkpoint inhibitors, and or people without pre-existing who get rheumatic complications. So collecting a large database, multi-site in Canada. I know they're mostly tertiary sites, but at least that's helpful. And one thing that really surprised me is we debated for a long time about the safety of hydroxychloroquine. And I said, how can that be considered even an immune suppressive? It's such a mild immune modulator compared to everything else. And apparently there is data that said hydroxy should probably go. So that really surprised me. Again, these are not always controlled, but we made the recommendations as best as we could with, I think, our clinical gestalt with a little bit of data to back it up.
I'd also add there was very little data on oncologic outcomes, though, right, Carrie? I think there was a lot of missing data, and it was difficult to make a balanced recommendation sometimes when you're missing that part of the equation. And I think that stresses the importance of collaboration with oncologists to collect that data as well, not just the flare rates and toxicity, but the oncologic outcomes, because I think that was an area of missing data, if I'm not mistaken, Carrie, when we
Yeah,
did the
and I
review.
think, Jeff, the part of that is because to report progression-free survival, overall survival, it's usually reported as median. And so if you're dealing with case reports and case series, you actually have no way of
Yeah,
comparing, like, someone was still alive at 9 months when we did this case report. That actually carries almost no information
totally,
on survival or cancer outcomes, so you can't compare it. And I think that's why that's such a tricky thing to do
totally.
unless you have a whole cohort that you're following.
Yeah, exactly.
So these are living guidelines, which means that they are going to be updated as at intervals when evidence becomes available, and Carrie gets the energy to do it. How should rheumatologists stay up to date on these guidelines? Where do they find them?
They are published on Magic App under the CRA guidelines. So when there are major studies and or when we do another update on our systematic lit review, those will be entered into Magic App. So Magic App is an ongoing sort of reflection of the evidence that's available. So that's where you can find it. But also I think next time when there is a substantial amount of increase in evidence and we want to redo the recommendations, we would likely publish an update.
Well, I really appreciate all of you taking the time to chat about this. It's a massive undertaking to produce, and I think it's a really valuable document. And thank you again for chatting with us about it, and take good care, okay?
Thank you.
Yeah, thank you for the invitation.
Thanks for coming.
That's it for this episode of Around the Rheum. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to Dr. Ye and Dr. Graham. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and write a review wherever you listen. It helps people find these interviews. Be sure to subscribe so you don't miss future episodes. Until next time, with Dr. Janet Pope, I'm Daniel Ennis. Thanks so much for listening.